Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion hepatic encephalopathy from the chapter of gastrointestinal emergency. So this is what we are going to discuss in this presentation: definition, causes, clinical features for hepatic encephalopathy, clinical gradings, and then investigation. What are the differential diagnosis for the hepatic encephalopathy? What are the complication and then management both out hospital and then in hospital. Coming into definition for the hepatic encephalopathy. So as usual, we will divide the term. First, it is called a hepatic encephalopathy, right? Encephalopathy. Encephalopathy. So hepatic means that is representing or that is denoting liver, right? Hepatic means liver. So what is mean by say encephalopathy? Pathy means P-A-T-H. Pathy means that is denoting disease or disorder. That is called pathy, right? So cephalic means what it is representing. Cephalic means that is our central nervous system. So if you are combining all things means there is a problem or a disease or disorder in the central nervous system because of the hepatic function failure or hepatic failure. That is called a hepatic encephalopathy. Okay, so the same statement only here we elaborated. It is a state, means hepatic encephalopathy is a state of disordered CNS function mainly because of the hepatic insufficiency. Insufficiency is nothing but that is the failure. So hepatic failure. Okay, the one more cause also we given for the hepatic encephalopathy, that is portosystemic shunt. Okay, two causes for the hepatic encephalopathy. First one is a hepatic insufficiency or hepatic failure. The other cause is a portosystemic shunt. So this is in easier term. Shunt means what? Abnormal connection between the two organs. That is called the shunt, right? Two organs or two parts. So portosystemic means, porto means that is representing our portal circulation. So which is happening in our gastrointestinal tract, venous circulation. That is the portal circulation. Systemic means that is denoting our inferior vena cava, superior vena cava. So all the connection here mainly in the gastrointestinal tract, systemic representing that inferior vena cava, that circulation, normal circulation. So this is, so whenever that shunting or whenever the abnormal connection happening between the portal and then systemic that circulation, that is causing the portosystemic shunt. So to easily understand this concept, so how the imagine or remember or rewind the gastrointestinal that venous circulation. So how it will be? So all the blood that is in the your gastrointestinal tract, that will drain into the portal vein, right? From the portal vein it will reach out your liver, right? In liver what will happen? That liver will detoxify the your blood. Mean detoxify means, so in liver what sorry, in your gastrointestinal tract what will happen? So ammonia is one of the product that is majorly it will produce in your gut or in the gastrointestinal tract. So this ammonia is one of the toxic agent or it is one of the neurotoxic agent that should be eliminated from our body. So what the liver will do means, so the liver take up the ammonia and then it will kept in the urea cycle, thereby it will convert into urea. That urea will excreted through our kidney. So this is the process will happen in the liver. So the liver what it will do, first thing it will detoxify the things. Second thing, it will absorb the all nutrients. So the two major function that will happen in the liver. So from that filtered blood where it will go means, then it will reach out your inferior vena cava, then automatically it will reach out your right atrium. This is what the circulation will happen in the gastrointestinal tract. So whenever the portosystemic shunt happening means, so it will, that blood will bypass or it will deviated from the liver, straight away it will drain into the inferior vena cava to the right atrium. So it is bypassing the liver. So it is bypassing the liver means what will happen? The detoxification won't occur. So the detoxification won't occur means, so we told, right, ammonia will straight away drain into the inferior vena cava. That ammonia again we told it is one of the neurotoxin, straight away it will cause the CNS disorder, that is altered mental status. So this is the reason. So two major reason. First one, hepatic failure. is the first reason. Second one, though you have an intact liver function, but there will be a problem in your circulation. So there is a shunt between the porto and then systemic shunt. So these are the two major reasons for your hepatic encephalopathy. The one more important thing, that CNS dysfunction or altered mental status is a reversible one in the hepatic encephalopathy. Okay, this is a reversible decrease in the neurological function. Mainly it will occur in the case of cirrhosis of liver or acute hepatic failure. Sorry. What are the causes or etiology for the hepatic encephalopathy? So one first thing is a chronic parenchymal liver disease like chronic hepatitis or cirrhosis of liver is one of the cause. Fulminating hepatic failure is also one of the cause. What is meant by fulminating means? Fulminating means sudden onset and then more severe form. So the form will be in a more severe, but it will that onset of the disease will be in a sudden. So sudden and then severe hepatic failure is also one of the thing. Acute viral hepatitis, hepatitis A, B, those are the things also causes for the hepatic encephalopathy. Drugs and toxins, surgical portosystemic anastomosis. So this procedure is called TIPS, TIPS, that is called transjugular intrahepatic portal systemic shunting. So this the procedure where we'll do means, so one of the surgical procedure mainly will perform in the case of portal hypertension, cirrhosis of liver cases. So mainly portal hypertension. So in the surgical procedure also may lead to the hepatic encephalopathy. Clinical features, what are the assessment points you will get means, first one regarding your consciousness, the person will be in a disturbance in the sleep rhythm, impaired memory or apraxia, mental confusion, apathy, drowsiness, somnolence and then coma. So it is vary from the mild confusion to the until the coma. So the different terminologies are apathy. What is mean by apathy means there is a lack of interest. So that is called the apathy. And then impaired memory. Apraxia means, so the person unable to perform some task or unable to perform the limb movements. That is called the apraxia. Because of that, cognitive related problem or problem in the brain, so the person unable to understand and then they are unable to perform the task or movement, that is called the apraxia. Regarding with the personality, childish behavior, and then the person sometime they may be aggressive, outburst also, euphoric state also. Euphoric means over excitement state. And then photer hepaticus, this means photer hepatic means there is a foul smelling of breath. So in the mainly in the case of liver disease, so in their breath we can get the foul smelling. And then coming into neurological signs, there is a flapping tremors or atraxis. Flapping tremors. So tremors we know that is a involuntary movement. Flapping tremor means the person unable to maintain the posture of extended or extended wrist. Means how to perform means you have to ask the person to outstretch his arm first. Outstretch his arm first. Second one, you have to ask the person to extend his wrist. So with this same position you have to ask the person. If the person unable to maintain this position means that is called the flapping tremor. Usually in flapping tremor what will happen means that hand will flap. So again they unable to hold in the same posture, that flap will happen, that is called the flapping tremor or atraxis. So second one is a exaggerated of tendon reflex and then extensor plantar reflex. Extensor plantar reflex means that is a classical sign, that is a Papinski sign, right? Papinski sign. So in the sole of the foot you have to make like a 7, or from here to down to up you have to make like a 7. So if the fanning of the toes, and then mainly normally what will happen means in exhausted Papinski sign, that your thumb will adduct, the remaining toes are will be in a fanning mode, that is called the Papinski sign positive. So if it is there means that is called the extensor plantar reflex. And then clinical grading ways, so we are grading between the 0 to 4. 0 means no abnormalities, 1 means alteration in the behavior, mild confusion, there will be a disturb in the sleep. Second grade means that is a lethargy, moderate confusion, atraxis will be there. Third grade or third stage, somnolent but arousable. Fourth grade there will be a coma. So what are the assessment point? Mainly first we'll focus on the pre-hospital. So remember or get back our emergency room assessment and management formula. First what we'll do, scene size of and then scene safety. So remember, safety of yours and the patient is the most important in this case of hepatic encephalopathy, because the person can vary from the varying status, means the person may be in a mild confusion state, or the person may be in a outburst also with one of the clinical sign we told. So whenever you are handling like these cases, make sure your safety and then your crew partner mean the same time the person's safety also we have to check for. Second thing, we have to check for the mental status assessment. So the usual we'll use is the AVPU scale, right? So awake and then alert. Some cases again the person may fall in whichever category. So some rather time the person will be awake and then alert to you. Some rather time the person only respond with an verbal or pain stimuli. Some rather cases the person in advanced state, clinical state, the person will be in an unresponsive state also. So coming into awake and alert, so we told some rather time what will happen means the person will be in a awake state, but in alertness wise he might be confused or disoriented will be there. So again that is why in A we have to make more focus whether the person is awake or not. If he is awake means whether he is alert or not, orient with you or not. That is also one of the thing we have to keep in mind. So the person might be in a disorientation or impaired behavior, incomprehensible speech. So those are the some note point where we have to check it out in the AVPU or mental status assessment. And then coming into next thing, we have to ask regarding the, so first one scene size up, second one mental status assessment, third one your ABCDE that you have to follow. Then we are coming into history collection. In history collection, so the same thing, you have to follow the sample format. The main thing in this is past medical history and then surgical history that we have to ask, because that portosystemic anastomosis that is told, we told one of the causes, and then cirrhosis and then liver failure also we told one of the causes. So to rule out those things, we have to ask the past medical history of any cirrhosis or hepatic failure or any surgical procedure they gone through regarding the portal systemic center. So those are the things we have to gone through. If any past history is there means whether he is on any regular medication or not, that is also we have to ask for. And then we have to rule out the any precipitating factors like constipation, any infection or renal function or renal failure, any gastrointestinal bleeding, constipation. So these are the some precipitating factor for the hepatic encephalopathy. So that is also we have to rule out. Along with this, then hypoglycemia and then hypokalemia. So those are the some precipitating factor for the your hepatic encephalopathy. These are the things while assessment we have to rule out. So investigation wise diagnosis. So this is mainly for your in-hospital management. So we will go with a regular investigation like CBC, complete blood count, LFT, liver function test, electrolytes and then urea, creatine, prothrombin time and then albumin, because prothrombin clotting factor and all synthesis in the liver only. So if any liver failure happen means, so we have to know about the coagulation studies. That is why we are going with an prothrombin time or albumin, and then ammonia level we have to check, because ammonia is one of the factor that is creating this much problem. So ammonia we have to check, EEG and then CSF and then CT scans. Why we are going with an EEG and CSF means to rule out the altered mental status causes. So whether that is because of hepatic encephalopathy or other causes, to rule out that we are going with an EEG and then CSF study and then CT scan. So what are the differential diagnosis? Subdural hematoma, drug or alcohol intoxication, Wernicke's encephalopathy is one of the cause, hypoglycemia and then hyponatremia. These are the causes for the altered mental status. And then complication, brain herniation, brain swelling. So this is the common one. Because of that, there will be increased risk of cardiovascular collapse, kidney failure, respiratory failure, sepsis, and then permanent nervous system damage, progressive irreversible coma, and then side effects of medication because of the cumulative effect. So already the person in the liver failure, still if you are administrating more and more sedatives or some other medication means, that will accumulate in your body and then that will create some problem, that is called the side effects for the medications. So the how we are managing the hepatic encephalopathy. First we'll think about the pre-hospital. Mainly in pre-hospital, so remember here, if the person is altered behavior or disoriented, or if the person is not responding, or he is not awake and alert, means you have to think about the airway patency, and then you have to secure with a definitive airway, that is our cuffed endotracheal tube. That is the first thing. Second thing, mainly in hepatic encephalopathy wise, it is only for the supportive management. So in between you have to check about your regular glucose level, and then we have to check for the any other causes for the altered mental status. So anyway we are going within the step by step. First you have to check the glucose level, and then you have to check the surroundings, either any misleading or any misuse of any drugs or any trauma related history, that you have to check for the in a pre-hospital region. So what we are doing in hospital means, there is a two major things we will focus in hospital. First thing, we have to decrease the ammonia production. Second thing, we have to eliminate or treat the precipitating factors. So this is the two management what we are doing in the in hospital. One thing, we have to cast out the ammonia, that is the one of the factor that is creating this much problem. So we have to cast out the ammonia. Second thing, we have to treat or we have to prevent the precipitating factors. So these are the two steps. So how we can precipitate that, how we can treat the precipitating factor. First one, IV fluids, dextrose and then saline. So because we told hypoglycemia, hyponatremia, hypokalemia, those are the some causes. So if the person in the hypoglycemia means IV dextrose, hyponatremia means, so based on the degree of hyponatremia we are going with an saline or 3% saline based on that. So correct any electrolyte imbalance. If the person in hypokalemia means, based on that we are giving potassium chloride correction. And then Rayleigh tube feeding, bladder catheterization also one of the supportive treatment we are doing in the precipitating factors. How we are dealing the ammonia load, how we have to reduce the ammonia load. This is called the ammonia reduction therapy. So ammonia reduction therapy. So how we are reduction means, first one, diet restriction of protein. Protein, why we are concentrating means, so from protein only our ammonia gets produced, means your protein get metabolized or catabolized into ammonia. So there is a at the end of your protein catabolism, the end product is a ammonia. So we have to try to reduce the protein diet. Instead of protein diet, anyway we should not completely stop the protein diet. Body needs some amount of protein, so we have to reduce, mean the same time we are increase the glucose diet. So this is one of the thing. And then you have to treat the constipation by the laxatives. So how we are treating the constipation? The first foremost step is a lactulose or syrup loose. So the or loose. So that lactulose is one of the thing we are using in the to treat the constipation. So here we have to aim for the 2 to 4 stools per day. So how we can make this one means, so you can give the lactulose syrup 15 to 30 ml 3 to 4 times a day. So this is the way we can give. So if the person able to take orally means, you can give the 15 to 30 ml of lactulose syrup loose 3 to 4 times a day. Thereby we can achieve the 2 to 4 stools a day. So through this what we can do, we can eliminate the or ammonia through the intestinal tract or through the intestinal GI tract itself. So that is the one of the treatment. Mean the same time, lactulose have some action on the ammonia production. It will diminish or it will decrease the ammonia production. That is also one of the cause. If the person is unable to take per oral means, then you can go with a rectal use. That is 300 ml of lactulose you can mix up with the 700 ml of normal saline. Per rectal route you can administer, and then like the same way like enema you can administer, and then you can make the person elimination. So second thing is a rifaximin, means first one, if you are that laxatives we are giving, right, syrup loose. So first thing we have to give the syrup loose for the 48 hours, means you have to continue the treatment. So you have to check after the 48 hours. So once after 48 hours, if there is no improvement in the ammonia reduction, or if there is no improvement in the mental status, means then we are adding one more therapy, that is the antibiotic rifaximin. Okay, so as like I told, first you have to give the laxative, that is your syrup loose or enema loose. So you have to check for the 48 hours. 48 hours means 2 days you have to check. If there is no improvement in the mental status, or if there is no improvement in the ammonia reduction level, means then we are adding one more therapy. We are escalating our drug therapy with the rifaximin. So syrup loose with rifaximin we are going. So the dose of rifaximin, you see, 550 mg orally we are giving BD dose, or you can go with an 400 mg TID dose they will give. Okay, this is the one of the rifaximin, we told it is a broad spectrum antibiotic. Okay, so this is also we can go for, either they will go with the BD dose or TID dose. This thing they will continue for the up to 3 months. So after that, if they want, they will stop, or the based on the condition they will go for the, but the course is 3 months they will go for. So one more additional drugs add on, we have a metronidazole and then vancomycin also. So one of the thing for the gastrointestinal infection. And then diet wise, mainly oral intake we have to we have to achieve the 6 to 80 grams per day. Vegetable protein is better tolerated than the meat protein. And then if you are finding any gastrointestinal bleeding, means that you have to address the gastrointestinal bleeding. 120 ml of, how we can address means 120 ml of magnesium citrate by by mouth, per oral you can give, or through the NG tube you can give every 3 to 4 hours until the stool free of blood. So if you are seeing any occult blood, black tarry stools, means then you can administer the magnesium citrate 120 ml every 3 to 4 hours per oral or through the nasogastric tube. So do your best. Shalom.